Thank you very much, Gavin. I thought that was fascinating. It provides the foundation, the philosophical and moral foundations for our discussion and deliberations today. So thank you very much indeed. I now want to introduce Eamonn Gaines. He's a Dubliner, but he's very welcome to Belfast nonetheless. He is a lecturer in Queen's University in scholastic philosophy. He's in the School of History in Queen's, and he specialised in the thought of St. Thomas Aquinas and more generally in ancient, medieval and contemporary philosophy. And he has particular research interests in ethics, practical ethics and medical ethics, and he will be speaking on ethical care for the sick and the dying. So, Eamon, you're very, very welcome indeed. Thank you very much, Eamon.
I'm masquerading somewhat as an outsider, a Dubliner. In fact, I've been living about sort of 10 miles down the road for the last 7 or 8 years. I married a girl from County Down, and sooner or later it reeled her back in and me with her. I'm going to talk about ethical care of the sick and the dying. I'm going to talk somewhat philosophically, although at a rather less advanced level than Gavin. They say the greatest delight for a teacher is to watch his student outstrip him. Gavin was my student in my very first year teaching in Queen's, and yes, he's left me choking dust, but in the nicest possible way since. I'm also going to speak a little from my own experience, because while I do teach in Queen's, I've taught in various other places, nobody has seen fit to give me a permanent salaried pensionable job, so I've found work wherever I can find it, including caring for the very ill, the very elderly and the dying. And one or two of the examples I use here, which I will of course maintain anonymity on, are in fact from my own experience of caring for people at the end of life. So I have a certain coalface experience as well as a theoretical interest. Now, some general principles when you're talking about the ethical care of anyone, when you're providing care, whether at a medical level or simply at an ordinary, the sort of examples Gavin was using of one's child or perhaps an elderly relative or parent. The first is simply non-maleficence, do no harm. Do no harm. You will often find if you talk to a medical professional and you talk about various options to deal with a particular instance, they'll say, well, we could do this, but we have to be careful because that has a cost associated. You talk to a surgeon about a problem that could have a surgical solution, and amazingly, the first thing the surgeon will say is, oh, we don't want to operate yet. The burdens of open surgery are such, and this patient is getting on in years and they're delicate in other ways, and we have to be careful. Because first, do no harm, don't impose an additional burden. Then there's the principle of beneficence, do good. So avoid making it worse, then seek to make it better. But it's a very measured and careful process. Always within the bounds of what is possible. You can't be expected to provide extraordinary levels of care, expending extraordinary sums of money that we don't have. You can't expect experimental treatments to work miracles in every instance. We have to be careful not to do harm, to use the resources we have wisely, and to do things within the bounds of what is possible. And always respecting the human person who is the patient. The word patient actually originally means one who undergoes. Patient is linked to the word passion. Passion, we'll see it in the coming week, the passion and death of our Lord Jesus Christ. Passion, what you undergo, what you suffer and experience, whether you wish to or not. The patient, the one who undergoes that, must be respected bodily and also in terms of their soul. A body and a mind bound up intimately together and inseparable. Now, in terms of end-of-life care, one of the resources I used to prepare this and to think about this was a report put together by the President's Council on Bioethics in the United States about 10 years ago now. If you get these slides from the website afterwards, I have all the resources at the end and the web addresses so you can download them and read them. But this particular very balanced report, balanced discussion, discussed end-of-life care and made the point that we've a problem. We've an ageing society. The average age in our society is going up. More and more older people are living longer and longer lives. Now, this is a thing to be celebrated, of course. I mean, it's great that our average life expectancy increases, that we can have longer lives with better health. But we have a problem. We do have a problem. There is no country in the developed world that has an above replacement level of birth. It's usually statistically presented as 2.1 children per woman of childbearing age in a population. There are different variants of it depending on exactly how you take down the statistics. But we do have a problem that we're getting an inverted pyramid. We're getting fewer and fewer younger people with more and more older people for whom they are responsible. Modern medicine means longer lives and means healthier lives. As I say, that's the thing to be celebrated, certainly. Previously fatal conditions are now well survivable. Heart disease. Out-of-hospital survival rates for cardiac arrest are increasing. On my way in here this morning, I live now in Downpatrick. I came in through Crossgar. There's an old disused telephone booth on the main street. Only instead of taking it down and getting rid of it, it has an AED, an automated external defibrillator. If you've ever seen one of those in action, they're near miraculous. They take a disorganized heart rhythm, return it to a normal heart rhythm, you get ROSC, return of spontaneous circulation. Bingo. Somebody may have months, years, even decades, continued life. Diabetes. If you read the Sherlock Holmes stories of Conan Doyle, a character in one of them, he was guilty of a terrible murder, but Holmes lets him off because you'll face a higher tribunal very soon. He says, yes, I shall. I'm dying. I have diabetes. That's almost a source of amusement to us. It's not in parts of the world where they do not have our technology and our wealth. In Africa, diabetes is still a death sentence, parts of Africa. In the developed world, my aunt was diagnosed with diabetes in 1937. She died about 10 years ago. 10 years earlier, and she would have died within 6 months or less. So these things are all now well survivable. But it does mean, because as a society, we are having fewer and fewer children. People are marrying later. They are choosing to have fewer children. Of course, we know that there's live debates, and particularly south of the border, a very live debate on how many children should come to the point of birth. But even leaving that aside, we have a situation where I speak as the parent of, as a father of 5 children, and if I had a £5 note for every time somebody has looked at me ushering children through the supermarket and heard the comment, "Oh, you've got your hands full." I also got the, "Do you know what causes that?" "Don't you have a television?" is another. We have a series of good-humoured and smiling replies, my wife and I, which we trot out on these occasions to deflect it. But it is the case. Of course, it's important not to judge. The woman once who said to us in the Kennedy Centre, "You have your hands full." "Well, we do, but it's a good complaint." And then she turned to my wife and said, "You're living my dream. I wanted that many children, but the Lord only gave me 2. So you never know what people's situation is. But nonetheless, as a society, we have made certain choices. We've moved in a certain direction, and that's to fewer and fewer children. So it does generate a difficulty. Okay, that PCB, President's Council on Bioethics, as I say, a very interesting collection of different people, religious and secular, from varied viewpoints, which produced very, very interesting documents. Once President Bush stepped down, was replaced by President Obama, it was reconstituted in a very, very different direction, and is at least less interesting from my point of view. They dealt with different problems. But the reports are still archived, and I've included the web address on the resources that I list at the end of this. How do we care? If we're caring for the elderly, if we're caring at the end of life, the questions we need to ask: are people willing to care? Are they able? Do they have the resources they need? They may be social resources, either from a government source or from a wider social source. What it will involve is family and friends making sacrifices. And that's a difficult thing to ask. And it's not always possible for people to make the sacrifices that they would wish to in terms of time and effort and energy and even money. health and social care professionals do need to support patients' real needs. That can be a difficulty too. One of the things that I found while researching this was the Liverpool care pathway, which was so controversial a few years ago. It seems to survive in various forms, though it was formally abolished. It wasn't a bad thing as it was originally constituted, but it ended up becoming a box-ticking exercise in certain clinical contexts, where instead of addressing the patient's real needs, the needs of the protocol were addressed. Every box was ticked, every step was fulfilled, yet no proper or appropriate care was being provided to that patient. I'm reminded, coming back to the Falls is rather it's an emotional experience in one way. My wife and I spent weeks and in the end months up and down to the Royal Hospitals here when our youngest was in neonatal intensive care. And at one point we were worried because there were monitors and things beeping and numbers, and we got to learn what the numbers meant. And one number was going frighteningly low, and I drew it to the attention of a nurse, and she said, "Stop it. You're trying to monitor the monitor. Look at your baby. Is she pink? Is she healthy? Is she moving? Is she breathing?" I said, "Well, yeah, with the support that's there." And she goes, "Right. So that very low number, it just means the monitor's off. Let me replace the sensor." "No, that hasn't done it." "Okay, let me rejig this, let me restart this, turn it off, turn it back on again." Works with a lot of technology. "Oh, look, the number's right, but we can see she's healthy. Let's look at the patient, your beautiful daughter. Don't look at the machines." The temptation when you have a protocol, when you have a system and a plan, is to work to the plan and not work to the patient. That needs to be addressed often enough. As I say, very good clinicians will see it. Very good nursing, and it was our experience that while the doctors were excellent, it was the midwives who made every kind of difference, who had that total patient focus. Societal support is generally available, but not always, and sometimes in ways that you wouldn't expect. There are systems in place to care, but systems will always have gaps. My late grandmother had a massive stroke. She spent the last year of her life in a nursing home. And when we went to approach the social security authorities in the Irish Republic in Dublin, where she lived, we were told she'd never depended on social services in her whole life, and therefore no help was available. She would have to pay for her own care. That she fell in a perfect storm of gaps in the system. I will comment that her 3 children, my father and his 2 siblings, made arrangements to provide for her care privately. And me and my siblings, I'm one of 7, and my cousins on the other side, all came together, we contributed, and in the end, none of us were significantly out of pocket. We all contributed, and her care was assured, and all of a sudden, without anybody intending it, the fact that we came from generously sized families where a spirit of generosity was inculcated meant that the lack of societal support in the formal state form was accommodated for by our tight family unit. It made an enormous difference. Okay, how do we care? There's going to be personal, ethical issues. We'll look at some of those in a minute. That also map out into larger social and political issues, and they have to be addressed and considered. The last thing to be aware of is that the family has taken a bit of a kicking in our society. We can all think of, I'm sure in our own circle of acquaintance, we can think of married couples we thought were solid and tight and would be together for the term of their lives, and those marriages have not survived or have collapsed or have broken apart in all sorts of ways. That can in turn introduce significant difficulties where, say, the adult child of an elderly person wishes to provide care, but she has the children and her ex-husband isn't willing to row in, and so, just to generate a hypothetical example, we can all conceive of circumstances like that. Okay. One of the things that this particular resource that I looked at, one of the things they discovered from the literature, from clinical experience, is that most care is provided out of the carer's pre-existing ethical stance. It's what the carer brings into that situation already, rather than anything that is inculcated in the process of learning to care. Conscientious and competent care often comes from already generally good people muddling through, and very often that is the case. They suggested, and I think it's a good point, that firm ethical boundaries are still needed. There needs to be some explicit statement, although an explicit ethical regulatory code can't make up for a lack of ethical commitment on the part of an individual carer. A danger of misguided compassion unfettered by rational principle. Doing something because you feel sorry for the sufferer has to be guided by actual principle. There has to be some clear guide as to what is genuinely compassionate care, compassio, to suffer with. If it's someone you care for, you have a connection with. I will say, I did it to draw a paycheck, but I cared for a couple of gentlemen, elderly male individuals who specifically wanted a male carer. I was short of work. I applied to a care agency. They said, well, with your background in this, that, and the other, you'd be fine, you'd be perfect for it. So I went and worked. And they particularly found that they were comforted by the presence of a male carer. It was intimate care. I had to wash them, I had to clean them. One gentleman couldn't get out of the bed and so had to be allowed to relieve himself in the bed, and we had to put things in place for that. And it had to be done in such a way that it didn't embarrass or humiliate him. Misguided compassion can come in, however, where you feel sorry for, you do suffer with them to an extent. You don't wish them to be in pain or to be in difficulty or to be uncomfortable. And a misguided compassion says, well, end the suffering. Now, that's where I suggest there's a clear case for a natural law virtue ethics approach. That's a tag we use. If you want to know what natural law dictates in this sort of case, what rationally discoverable principles of good action dictate, I direct you to Dr. Kerr. If you listen to him, that's exactly what I'm talking about. And that provides a very firm foundation. Now, ethics and law, the two come into play. There's a great deal of overlap, particularly in extreme situations, particularly in situations of somebody being kept alive by ventilation, somebody being kept alive by an endotracheal tube and the pump taking over their breathing function, somebody being kept alive by feeding directly into the stomach one way or another. However, we have to recognize that in some ways law can be a blunt instrument. It's very effective at dealing with certain things, but much of what happens in the sick room is beyond scrutiny. I use the example here of M. He was dying. He was 78 years old. He had multiple chronic illnesses. He'd had an injury from which he hadn't properly recovered. He got a hospital-acquired infection. He was in a great deal of pain. 3 a.m, when you're the only person with him and he's nearly crying with pain, is a very difficult position to be in. He was prescribed powerful analgesia, fatal in too great a dose. There was a prescription, there was an instruction, there was a limit placed. I and the other carers were trained. We were given strict limits. We were overseen by a nurse. The level in the actual, it was oral analgesia, the level in the bottle was being marked and monitored and checked against our paperwork. And the doctor was coming in every 2 or 3 days to check it again. It was extremely tightly monitored. But having said that, they were trusting me and my colleagues to be ethically sound, to behave properly, to give him the right amount within the limit, to control the pain, so that he was not in unbearable suffering. We succeeded in doing that. He lived out his natural term. Now, law might not look or find evidence of an overdose. He was depending on us to be decent human beings as his carers. I'm happy to say my colleagues and I, we did. We cared for him. He managed his pain. In the end, he stopped taking the painkillers. He drifted off to sleep. He drifted deeper and deeper into unconsciousness, and ultimately died a natural death. There was a carer sitting with him, called his wife. He passed away at about 4 a.m, but he had been ill for quite some considerable time. Now, this leads then to the question of human worth. what's the value, the worth of a human life? Does it depend on simply being human? Does it depend on an additional factor? In some contexts, we might value one person more than another instrumentally. When I need a doctor, you know, the classic one, is there a doctor in the house? Somebody famously called it when an actress collapsed in a theatre in Oxford, and up jumped 4 doctors, 2 doctors of divinity, a doctor of philosophy. If I need a medical doctor, I'm going to value that person more than a doctor of divinity, for example. That doesn't contribute to human worth, but simply that I need the help of that person, that skilled person. There are possible principles that might guide us, and these, again, I'm relying on this interesting report that I mentioned. Autonomy, utility, practical value, quality of life, equality. Now, autonomy, my own power to choose and judge. Utility, my usefulness, productivity, economic or social. Quality, my ability to exercise human capacities and enjoy the use of them. We do value these things, and it's worth valuing them, but not in an absolute sense. We do take them into account, but they are not the final source of value. Equality. My worth is equal to that of any other human being simply in virtue of our shared humanity. My worth, yours, ours, each of us individually. So they are valuable aspects of human life. But if we take equality, rooted in that fundamental humanity that Gavin outlined so well, if we take equality as an absolutely fundamental value, it's based on our shared human nature alone. It guarantees decent treatment in the face of our equal vulnerability to sickness, old age, dementia, death. We are each of us capable of being brought low by these things and in this way. It's an American ethicist, Gilbert Meilander. He was at the Lutheran University at Valparaiso. He described it as the floor of human dignity. It doesn't set an upper limit, but a ground level, foundational limit for human dignity is an ethic of equality. Even the most diminished are not and should not be entitled to the care to which all of us are entitled. It particularly applies in something like dementia. That can be a terribly distressing situation where you no longer recognize the, shall we say, the personality that you once knew. You can no longer talk to that person and share a conversation with them. I cared for one gentleman. He was incoherent. He was a retired police officer. He kept talking about launching investigations. We have to investigate Croke Park. This was his big thing. And he circled back to it. I used to sit with him a couple of evenings a week to allow his wife some respite. And at one point he stopped. He looked at me and he said, I'm sorry, I don't know your name. I said, I'm Eamon. I told him 4 times already that evening. And he said, yes, you must forgive me. He said, I'm suffering from Parkinson's disease, and I have occasional episodes where I'm not quite sure who I am, and so I might behave a little strangely, but you mustn't pay any attention to that. Or if I'm a bit bad-tempered, I do come back to myself. Now, actually, in the 5 months in which I was providing these couple of respite evenings, that was the only time he was lucid and coherent. What he thought was an occasional episode was in fact his normal state. The occasional episode was when he came back to himself. For that brief moment, he made perfect sense, was completely lucid. Wonderful to talk to. But what an ethic of equality dictates, founded on our human nature, is that the respect and care which I was to provide, and indeed there were various carers in which we all provided to him, were never denied despite the fact that he was not in contact with us in any meaningful sense for a great deal of the time. There is a temptation to devalue a life with little or no independent function, especially where the burdens on a social or economic high-utility carer are very great. In other words, you could be doing so much better with your time than caring for someone who doesn't even know you or doesn't even notice. What we're suggesting here is that a fundamental commitment to equality based on our common humanity nonetheless dictates that that is a thing of value in and of itself. Now, brings us neatly to terminal illness, because that's where it's most difficult to assert the value of human life, because it's an illness which cannot be effectively treated. Clinicians are morally certain the patient is going to die. Now, that doesn't mean an absolute certainty. We can never exclude the miraculous. We can also never exclude the otherwise unexplained. But moral certainty is best defined as the certainty we have when we make an important decision ourselves, that we're sure it's the right thing to do. We're sure this is what's going to happen. Given the totality of the circumstances, that is to say, if I'm a clinician treating a particular kind of very rapidly advancing cancer, where there's only one available treatment, it's available in one private, very experimental place in the United States, and it costs $6.1 million to get in there. I don't have it. The NHS doesn't have it. We can't raise it. We've run out of options in this instance here and now. So that's a terminal illness, at least in this concrete circumstance. The death of the patient is not at issue. Okay, we know this patient is reaching the end of their life. What care is to be provided? What can we leave out? Well, there are a couple of fallacies. There are a couple of false steps we can take. Vitalism, let's keep the physical organism, the integrated human body, let's keep it alive, functioning at all costs. That's to fail to realize or to acknowledge the limitations in time and space and energy and strength that come with the human body. It has a limit. Spiritualism, free the person's spirit by terminating their life. There was a ward of court case in the High Court in Dublin about nearly 20 years ago now, and a theologian, a Catholic theologian, contributed a paper as part of the brief for the people who wanted to end nutrition and hydration for a patient who was in an intermittent comatose state, sort of raising and lowering consciousness but never fully conscious. And his suggestion was, and it was taken up by the family, was to free this person for a fuller life with God by withdrawing nutrition and hydration. So it was a sort of a spiritualist argument. If those of you who know your church history, if you find an echo of certain forms of Gnosticism around the time of St. Augustine, you wouldn't be far wrong. There was a particular kind of ascended spiritual master in some of the Gnostic groups who would go off into the mountains and starve themselves to death to be free to join the pleroma, the divine nature, and so on. But essentially by a form of suicide. This obviously isn't that. It's rather freeing the person, but by a form of starvation. Physicalism, if only physical life exists, if it's too painful, degrading, or humiliating, it should be ended. Again, it's to fail to recognize the inherent value of human life itself. All share the refusal to recognize death as a natural part, strange as it is to say it, as a natural part of life. That it is the final end for each of us in the sense of our earthly span, and we need to recognize it and accept that it does come at a certain time. How do we care for the dying? Well, nutrition. We provide food as long as the patient's capable of taking it in. We don't make a decision. We ought not ethically to make a decision to withdraw it at a time of our choosing, but to cease to provide it when it can no longer be effectively taken on. Hydration, again, by mouth, when the patient can take it, by other ways. I mentioned the gentleman I cared for. We had at various points intravenous hydration, which stopped being practicable because all his veins had collapsed. They were never in a very good state. It was then provided subcutaneously, and his body stopped taking that in. And then he died within a couple of hours. His body simply stopped absorbing it. And there was no point in packing him full of fluid so that he'd be bloated. He couldn't take it in. There was nowhere left to put it. Artificially, if needs be. Medication to control symptoms we're no longer going to cure. We will at least relieve pain. Surgery can be considered to extend life with the patient's informed consent, but that's very much an individual decision for the patient, for the next of kin. Analgesia, whatever kind or quantity is needed. I'll mention in that connection, a friend of mine, we were fellow parishioners in Dublin. He's a legal figure. He had done a lot of medico-legal work. He had represented various hospitals and got to know various doctors. His father was dying of cancer. He was not happy that the palliative care was everything it should have been, but it was in an acute hospital, not in a hospice. So he was trying to work this out and trying to deal with it all. His mother was dead some years. His siblings are living in other countries. He was the only one to do it, and he was extremely busy with his legal practice. He was just trying to keep everything going. He ended up speaking to a friend, a doctor, who said, "You need to talk to Dr. So-and-so." He did. This particular person came in, went to the acute hospital, visited the father, looked at everything that was being done, and cancelled all the painkilling prescriptions. His father went from being near comatose 24/7 to sitting up in bed and interacting, because a palliative care specialist, with the specific and quite detailed knowledge she had, was able to bring a whole raft of specialist pain control measures to bear that also looked after quality of life. His dad then went home hospice care, and the following week was sitting up in the sunroom at the back of the house playing his regular game of chess with his old work colleague. They kept a regular Wednesday morning, mid-morning appointment. Now, the acute hospital were not trying to kill him. They were not trying to give him substandard care. Their medical specialities were just in other fields. They weren't specialists in palliative care. They didn't have the specific knowledge that was needed. And once the specialists came in, they were happy to acknowledge it. They were doing their best with the toolbox, as it were, at their disposal. It needed a different toolbox and a different, as it were, technician to wield those tools. We need to respect patient autonomy, of course. We need to respect their entitlement to decide their own treatment. Accepting their acceptance of the inevitability of death. If they recognize that they're coming to the end of the road, we need to understand and respect that. We must refuse intentionally to end the life. It's not our job to take a life, but to recognize that a natural process is playing out. We must respect their refusal of treatment. There was a case before the Court of Protection in London about 18 months, 2 years ago. The judge who decided, Sir Peter Jackson, I speak as a non-lawyer, as a philosopher, but I find his judgments very well reasoned and well worked out, though I don't by any means always agree with them. He ordered that a somewhat mentally impaired individual, homeless, diabetic, should not undergo a forcible double foot amputation. He was diabetic, end of life in diabetes, very often peripheral circulation is very poor, the feet get diseased, they get gangrenous, they have to be removed if the patient is to survive. The patient himself said, "Yes, I've been intermittently homeless, yes, I live in shelters, but I've been autonomous, I've been capable of directing my own life. You do this, you put me in a nursing home. And I'm 72, and I have diabetes, and I have heart disease, and I think I'm just reaching the end of the road, and I want to be allowed to reach the end of the road. There's nothing for me to fight for here. I'm never going to be leading a full and independent life, and I've recognized that I've reached a limit. And the surgery is so burdensome that it itself may kill me." The doctors felt they should go ahead. The judge said no, he should be allowed to decide to refuse that treatment because it's not going to make him better, it's not going to cure him, and it is in the end prolonging the inevitability. He has a couple of years left, but his health is so poor. In that circumstance, I think it is justifiable to allow him to refuse that treatment for himself, which he was able to do. I don't say that I'm terribly certain of that. I'm open to argument on it, but when we get into these cases and into these situations, there does have to be an argument. It does have to be thrashed out. The answer is not always obvious, even though the principles are clear and ought not to be transgressed. This is particularly true where it's burdensome or excessively painful treatment. Okay, pain relief enables tolerable quality of life. It can be given in very high doses in terminal cases, but the days of a morphine pump being the standard go-to tool, the impression I get from the literature and from some conversations I've had is that that's less and less the case. It's a much more variegated, careful and detailed consideration now. A central question is always the intention of the one administering. What does he want to do? What does she want to do? Does she want to relieve pain? Does she want to end life? That will make a significant difference. That will determine the drug chosen and the dose and so on. and it needs to be the person who knows this area of care intimately and in a detailed way. Patient needs to be involved in their own treatment to the greatest extent possible. If somebody's in a long-term coma, it's obviously more difficult. They need to be allowed consent or refuse having been given information. That can be a problem. The old bioethics study group, sadly now defunct, I remember having a discussion once with the then president of the Royal College of Physicians of Ireland. And he was saying that the tendency is to dump a load of information on a patient and then say, now you decide, and it's informed consent. Where he said his practice was to come in and say, this is what's going on, explain it, wait for them to ask questions, see that they understand, and then say, we have 2 or 3 options, however many it may be. But he said he will clearly advocate for what he sees as the best option, but then says, I will not impose, I cannot impose, you must tell me your preferred option, but I'm an expert and I will give you the benefit of my expertise. It struck me as perhaps a better worked out system. He said, particularly where a patient is deeply frightened and very often deeply ignorant of what they need to know to make these decisions, whereas he as a clinician is well informed, but he said equally, he doesn't have skin in the game. His patients do die, and he carries on in his medical practice because he can't save everyone. So he said there has to be a balance in that. You need to decide, should the patient be told they're going to die if they don't already know? Very often they will know, and the general impression tends to be, and again from talking to clinicians, that they prefer the patient to know, to be told in an appropriate way at an appropriate time. Should all the next of kin be told, to what extent will they be able to cope? Okay. To summarize it very briefly, if you're caring for someone in that position, there's a rhyme that an ethics lecturer taught me years ago, and it stuck with me. Thou shalt not kill, but needst not strive officiously to keep alive. You don't need to save life at absolutely every possible cost, but you may not kill, ever. So accepting the inevitability of death as a result of a disease process is not the same thing as actively hastening it. When it's inevitable, you can carry on impeding it, but at the cost of distress and difficulty and pain for no conceivable benefits. There has to be a balance struck. You can accept that it might be hastened by reasonable care. That is to say, a reasonable approach to analgesia may have a negative consequence. Double effect that Gavin outlined so well. Okay, briefly, recognition of death. This isn't directly relating to our situation at end-of-life care, care in old age. When you're recognizing injury leading to death, and you're talking about organ donation and so on, we have to recognize whether death as a process has occurred and has been completed. Crudely, lack of pulse and spontaneous breathing. Gavin mentioned triage. If you've ever seen a triage sort, it's very, very simple. You pop open their airway with the patent airway, they're not breathing, you have multiple patients and limited rescuers. They're tagged not black anymore, they're tagged white. When a white tag is put around their neck, emergency medical personnel just won't touch them. They're for the body collectors afterwards. In a major multiple casualty incident, that's simply what happens. That's wearing my other hat. I used to be an emergency medical technician also. Lack of pulse, spontaneous breathing. Where there is breathing or where it's being supported, where they're in long-term comatose state, we tend to use neurological criteria. That assumes the brain is an integrative function for the body. That seems to be borne out scientifically and experimentally. Although a very interesting neurologist in England, Professor Eamon Tallis, maintains the brain has an integrative function, but there is a non-physical aspect to human life that is not reducible to brain activity. The brain isn't what keeps you alive. The mind, the soul, is. Professor Tallis is an atheist. I'm not quite sure how, but he is. Lack of brain function tends to suggest lack of bodily integration, and that's what we call death. Okay, I'm not going to dwell on those except to say that there are different levels of brain function and there are different ways of assessing those. In all 3 sectors, when there's an absence of brain function, the scientific conclusion is that life is absent. The church tends to accept that, but makes no technical determination. Briefly, I'm probably running low on time, am I? 5 minutes, okay. Euthanasia. Ethical principles that apply, we're going to hear over the course of today about ethical principles at one end of life. Well, they apply to the other. Human life is a continuum. It's not radically divisible. Even as we talk about infancy, childhood, adulthood, it's one continuous human life from conception to natural death. So what about old, sick, and expiring lives? Well, one answer to the suffering at the end of life is euthanasia. Greek root, eu, happy, thanatos, death, a happy death, sometimes called mercy killing. Two conditions are central, method and intention. The definition of euthanasia I use here is one the Congregation of the Doctrine of the Faith came up with in 1980, but I think it's compelling simply on its own standing anyway. An action or omission, doing or leaving out, which of itself or by intention causes death in order that suffering may in that way be eliminated. So it's an action or omission to cause death to eliminate suffering. Simplest case, terminally ill patient, no hope of recovery, asks for a lethal poison or procedure, intends to have their own death brought about, requires or requests the assistance of medical and nursing practitioners to do so. The usual justification is it's in the patient's best interest to end their suffering in this way, or it's entailed by respect for their autonomy, their ability to make their own decisions for themselves. Now, that's what it is. There are alternative cases that I think there are bad arguments, but there's at least some argument for respecting their autonomy. I think autonomy ought to be respected, but not to that extent, and I think it's wrong to do so. But non-voluntary euthanasia, where the patient might be surmised to have wanted it, they're in a long-term coma, persistent vegetative state, it's sometimes called, the next of kin decide it. Now, a living will and advance directive has I think the most, as far as I'm aware, the most tenuous footing in law in this jurisdiction. Tends to be decided case by case in the courts. But nonetheless, where there's an expression of a particular desire, that can sometimes be taken into account. The patient's consent is impossible to obtain. It's very often obtained by way of litigation. The Schiavo case in the States that made such a splash, the Ward of Court decision in the Irish Republic, where it wasn't even a persistent vegetative state. I dislike that language, but it's the one that's used. Rather, it was an intermittent state. The Tony Bland case, which I think went all the way, certainly to the Court of Appeal in London, if not to the House of Lords. But it was decided in a forensic forum because it ethically wasn't clear and legally wasn't clear. And then finally, involuntary euthanasia, killing carried out without regard to the patient's wishes, against the patient's last known wishes. Again, justified by best interest, justified by the next of kin, consenting. There is always the possibility that euthanasia is to assuage family or friends' emotional distress. That can play into the decision. And again, to relieve that distress is not an ignoble aim, but it's the misguided compassion I mentioned. It cannot be a guiding ethical principle. Consent from those who are uneasy about it can be coerced or cajoled. Who knows what happens in a very, very private family discussion? A very private discussion among friends or next of kin. Okay. Active versus passive euthanasia. Active euthanasia, deliberate action intended to bring about the death of the sufferer. Passive euthanasia, withdrawing treatment or support in order to allow the natural process of death to occur. The terms are often used to blur the distinction between killing and allowing to die. To be absolutely clear, I think the active-passive distinction is very often a distinction without a difference. I allow someone to die by withdrawing burdensome treatment. No more chemotherapy. I'm the next of kin, he's comatose, I have to decide, no more chemotherapy. We're not holding back the tumours. The secondaries all over his body. Let's keep him comfortable. It's time to let poor Granda go. That's withdrawing treatment. That's not euthanasia of any kind. It's time to withdraw this burdensome treatment. What burdensome treatment? Peg feeding. It's where nutrients are introduced directly into the stomach, into the abdomen, where the body is still capable of absorbing them, digesting them, and continuing homeostasis, continuing the ongoing process of ticking over as a live human being. That's often presented as passive euthanasia. I would suggest it's an active, ethically culpable omission of ordinary care, albeit by rather medicalized means. Now, just a couple of cases. I will ask you to reflect on them. I won't necessarily give definitive answers. Terminal cancer. Chemotherapy could delay death by 6 to 12 months. Patient opts for palliative care only. I would argue, morally acceptable. The patient recognises the inevitability of their own death. They've got their family gathered around them. They're coming to life's end and they wish to accept it at this point, rather than, chemotherapy is a fairly burdensome treatment. Structural brain, central nervous system injury, long-term coma, patient contracts pneumonia, aggressive treatment is avoided, symptoms are managed, patient dies. Is that a case of euthanasia? Is that a case where we could legitimately decide not to provide aggressive treatment, bearing in mind pneumonia is a very well-treatable condition? One in that collection I mentioned, one commentator says, historically it was called the poor man's friend. You were healthy and happy and hale and hearty, you hit 70 years of age, you contracted pneumonia, relatively painless, and you'd be dead in 3 weeks. No lengthy period of being invalid, in bed, unable to care for yourself. But now it's readily curable. Now, in that case, I would suggest the pneumonia ought to be treated in most circumstances, but I don't know that one can say that absolutely. The last one then, long-term comatose patient, self-sustaining in terms of breathing, respiration, circulation. Feeding is by nasogastric tube, later by peg feeding directly into the abdomen. Maybe we withdraw nutrition and hydration to allow this patient to die. I would suggest that that's a misuse of language. You're not allowing to die, you're actively withdrawing basic sustenance. I'll lastly just mention, we'll hear later, I think, from Tracy about the slippery slope. I will mention that the slippery slope isn't coming, it's already here. Belgium legalised euthanasia a number of years ago. These are 2 cases I came across in my research. Nancy, alias Nathan Verhelst, was suffering incurable, non-terminal psychological pain, gender dysphoria. Born a girl into a family of boys, mummy wanted another boy and constantly tried to make Nancy into a boy. Nancy in the end grew up to want to be a boy, be a man, and sought gender reassignment surgery, radical double mastectomy, surgical construction of male genitalia, synthetic male hormones administered. The one photo I managed to track down of, I suppose one ought to say at that point, Mr. Verhelst, that's what they wish to be called, it was of this incredibly muscled, tattooed, burly-looking man. Very unhappy after the transition. After 6 months of counselling, was killed by lethal injection. The counselling and the killing were undertaken by Dr. Wim Distelmans. These are matters of public record. I'm not maligning the man. And Dr. Distelmans will quite clearly say this is what he does, as well as being an oncologist. The deadline for review of the case has passed. If euthanasia is undertaken improperly in Belgium, there can be a criminal prosecution under Belgian federal law. No action's been taken. The decision on police action or prosecution would have to come from the Federal Euthanasia Commission, chaired by Dr. Wim Distelmans. Nobody else wants to touch it. Dr. Distelmans, it must be pointed out, has since stepped down. He's been replaced by someone else at the head of that commission, but he was the one who drove it through. He was the one who managed it all. Another case, again a Belgian one. Oddly enough, Flemish sources are frequently translated into English, which is why I can find these sort of cases relatively easily, and they're perhaps rather more open than we are here. Suffered from anorexia, suffered sexual abuse from Dr. Walter van der Eycken. He's an international expert on anorexia. He was suspended by the Catholic University of Leuven as a professor in the medical faculty. She sought for her psychological pain and obtained euthanasia because it's incurable suffering, though it's by no means terminal. Okay. Our ethical principles are life is an inalienable good. We must avoid any act of self-destruction. We must avoid anything that damages the nexus, the interrelating web of social and familial relationships. Any act of self-destruction always damages that. My act of suicide, should I choose it, is my responsibility, of course, but when I invite another to take an active part, I share the blame out with them without either our loads being diminished. Theologically, speaking as Christians, we must recognize that life is a gratuitous gift from God. A refusal to accept that gift when given is an offense against God's goodness. So we have good human, general human reasons we share with any reasonable human being. We also have reasons as people of faith to say an absolute no. Suffering can have a redemptive value, can have, it will not always necessarily have. Euthanasia, like suicide, counts as the deliberate killing of the innocent. Death is certain for each of us. We do accept it when it comes at the end of life. We oughtn't to seek it, and we can choose only proportionate care in response to it. When we seek euthanasia, we reduce the human to the level of the merely animal. We harm the relationship with the doctor. We harm the relationship with families. The harm done to the victim is multiplied and spread over a series of social, familial, professional relationships. And the harm that is done does not tend to end with the death of the person harmed. Some of the literature, it's heartbreaking to read. The central event for the next of kin after a case of euthanasia becomes the act of euthanasia. There isn't a happy memory. For some, my own memory of, we chose to forego any further extraordinary treatment when my father was reaching the end of his life. He had 2 conditions, either of which was operable. Both together were inoperable, and they created a situation where he simply couldn't survive. He was slipping away. Oddly, it's a happy, in a strange way, a happy memory. He hung on for the last member of the family who was in Ireland, but had to travel the length of the country to get to the hospital. He was alive until they got there. And I thought, wasn't it great that he waited till my brother got there from Limerick? And then I realised it wasn't my brother at all. It was my brother's wife, who was always Dad's favourite daughter-in-law. She got there, and she leaned in and she took his hand and whispered in his ear, and he slipped away. And in a matter of a few minutes, we'd sort of had it on the monitor, but they turned off the alarm, he had slipped away. There's a sense in which we recognised a natural end. We grieved. We grieve still. When you love, you never really let go of that sorrow that somebody has gone from you. But we did everything we could for him. The doctors, the nurses did likewise. And we recognised the end when it came. And the end when it came, as I say, was his favourite daughter-in-law. One of his 2 daughters is there, the other lives in the States. But his favourite daughter-in-law was there, and he felt that was it. He had said goodbye and he could go. By contrast, when you look at the literature and you look at the aftermath, the psychological, social, emotional aftermath, to say nothing of the harm to the person killed, the aftermath of an act of euthanasia is that it becomes central. We didn't let Dad go. We killed him. We didn't let Granny slip away. We forced the barbiturates down her throat. Or, as is the case in Canada now, the state of Washington has given Canada help with their euthanasia protocol. Lethal injection in the state prison in Washington, that protocol is now the protocol for at least 3 Canadian provinces to perform euthanasia. Culture of death, how are you? Thank you.